For Psychopharm Archive, I am a Consultation-Liaison psychiatrist and academic physician. Case file 001, the patient. He was 21 years old, and he had been on the inpatient psychiatric unit for 19 days. He had arrived in the emergency department on a winter evening, brought in by campus security after a resident assistant found him in a dormitory stairwell, unable to explain what he was doing there. He was a third-year mechanical engineering student at a state university an hour from the hospital. Before the voices, his professors had described him as quiet and precise, the kind of student who submitted problem sets early and sat in the second row. He kept a notebook of derivations he planned to revisit before qualifying exams. By the fall of his third year, that notebook had gone unopened for months. The voices had started 2 years earlier. At first they were intermittent. A whisper during a lecture, his name called in an empty hallway. By the end of that semester, they had organized themselves into something more coherent. They commented on his coursework. They told him which classmates were watching him. During midterms of his second year, they grew loud enough that he could no longer follow a proof to its conclusion. This admission was his third. Risperdal had not quieted the voices. Abilify had not quieted the voices. On hospital day 3, after a team meeting and a phone call with his mother, the decision was made to initiate clozapine. Clozapine is the most effective medication for treatment-resistant schizophrenia. It is the only antipsychotic with clear superiority in patients who have failed at least 2 prior agents. For this patient, it was not a routine medication adjustment. It was the final pharmacological instrument available to return him to his own life. The titration was cautious, 12.5 milligrams on day 1, 25 on day 2. Then slow upward increments, with daily vitals and weekly CBC monitoring through REMS. The risk evaluation and mitigation strategy. This was a federally mandated safety framework, fully terminated in June 2025, that required centralized reporting of lab values to ensure the benefits of the drug outweighed the risk of severe neutropenia. The team had managed other titrations before. He appeared to tolerate it well. On hospital day 17, day 15 of his titration, he told the morning nurse that the voices were quieter than they had been in 3 years. On hospital day 18, he asked his social worker whether the university would let him re-enroll for the spring semester. On hospital day 19, at 9 o'clock in the morning, he walked to the nursing station and said he thought he was coming down with the flu. The presentation. He was usually meticulous about his hygiene, and the team had come to read that as a marker of early stabilization. That morning, his shirt was on backward. His hair was unwashed. He moved slowly down the hallway as though the distance from his room to the desk had cost him more than it should have. His temperature was 102.4 degrees Fahrenheit. His heart rate was 115 beats per minute at rest, notably disproportionate to his level of psychomotor activity. His blood pressure was preserved. He reported body aches, a mild cough, and profound fatigue and body aches. In a high-volume inpatient psychiatric unit, these findings are statistically a viral prodrome. The resident on service ordered acetaminophen, a portable chest radiograph, and a basic metabolic panel. She also, because the patient was on day 15 of a clozapine titration, and because she had been taught to do this, added a complete blood count with differential, a C-Reactive protein, and a troponin. The chest radiograph was unremarkable. The metabolic panel was unremarkable. The CBC returned first. The absolute eosinophil count had doubled from the value recorded on his most recent weekly draw. The C-reactive protein returned next. It had risen from under 5 milligrams per liter at baseline to 84. The troponin, ordered almost as an afterthought, returned at the edge of the reference range. Elevated enough to be noticed, not elevated enough to explain the picture on its own. The resident called her attending. The collapse. At 2:14 that afternoon, the patient stood from the edge of his bed to walk to the unit bathroom. He made it 3 steps before his legs buckled. The technician who caught him later reported that his skin was cold, his lips had begun to turn gray, and he could not finish the sentence he had started when he stood up. A rapid response was called overhead. By the time the team arrived, his heart rate was 138. His oxygen saturation was 89% on room air. His respiratory rate was 32. He was placed on supplemental oxygen and transferred from the psychiatric unit to the medical intensive care unit, a transfer no one on the ward expects to make for a patient who had been stable at breakfast. A bedside transthoracic echocardiogram was performed within the hour. The findings represented a sharp departure from what a 21-year-old heart should look like. The left ventricle was dilated. There was global hypokinesis. The ejection fraction, which should have been in the normal range for a patient his age, returned at 25%. This is the point in the clinical trajectory where the case becomes a physiological contradiction. A 21-year-old with no prior cardiac history, no family history of cardiomyopathy, and a normal admission EKG does not lose 3/4 of his ventricular function over the course of a morning without a cause. Viral myocarditis could produce part of this picture, but not comfortably on this timeline and not without more convincing prodromal evidence. Stress cardiomyopathy did not fit the demographics or the context. Structural disease had not been evident at baseline. The clinical team was left with one major new variable, the medication that had been titrated into his system over the preceding 15 days. Clozapine was held, cardiology was consulted, the eosinophil count, rechecked that evening, had doubled again. The mechanism. To understand what was happening inside this patient's chest, we have to move away from receptor pharmacology and toward immunology. Clozapine is extensively metabolized in the liver, principally through cytochrome P450 enzymes, and a small fraction is bioactivated to a chemically reactive natrinium ion. Per Mohammed and colleagues demonstrated this intermediate in human liver microsomes in 1995, and Williams and colleagues later showed that cardiac tissue itself could participate in similar bioactivation. The leading mechanistic hypothesis is that this reactive metabolite, or possibly the parent molecule itself, functions as a hapten, a molecule too small to trigger an immune response on its own, but capable of doing so once it binds covalently to an endogenous protein within the cardiac interstitium. At that point, the immune system is no longer reading myocardium as self, it is reading a Hapten-Protein complex as foreign. The exact immunological classification remains debated. The literature often frames Clozapine-induced myocarditis as a type 1 IgE-mediated hypersensitivity reaction, but biopsy evidence showing prominent eosinophilic infiltration suggests a more mixed process, one that may overlap with delayed hypersensitivity pathways. The nomenclature remains contested. The downstream injury pattern does not. Once the Hapten-Protein complex is recognized, eosinophils are recruited into the myocardium. That explains the doubling of the absolute eosinophil count in the morning laboratory data and the second doubling that evening. What appeared in the peripheral blood was the hematologic echo of a process unfolding inside the heart. Eosinophils are among the immune system's oldest cytotoxic instruments. They evolved to destroy multicellular parasites by releasing granular proteins that damage cell membranes at close range. Major basic protein, eosinophil cationic protein, eosinophil-derived neurotoxin. These are not subtle mediators, they are powerful cytotoxic proteins designed for targeted cellular destruction. In this patient, on day 15 of a clozapine titration, those immune cells appear to have been directed against the myocardium. The timing is not incidental. A presentation between days 14 and 21 is consistent with the kinetics of an adaptive immune response to a newly formed antigen, recognition, sensitization, clonal expansion, and then concentrated effector injury. In Ronaldson's 2011 analysis of 75 cases, 83% of clozapine-associated myocarditis presentations occurred within exactly that window. This patient's presentation fell within it to the day. Risk factors identified in the surveillance literature are more clinical than molecular. Faster early titration increases risk. Concomitant sodium valproate appears to increase risk. Older age may increase risk. More recent work, including the 2020 genetic analysis by Lacaze and colleagues, suggests that host susceptibility also contributes substantially, though the full molecular chain-linking exposure, hapten formation, immune recognition, and myocardial injury remains incompletely mapped. But the diagnostic structure in this case was already difficult to ignore. Second-week clozapine exposure, fever, disproportionate tachycardia, rising C-reactive protein, eosinophilia, a troponin leak, and sudden severe left ventricular dysfunction without a better alternative explanation. The diagnosis was Clozapine-induced myocarditis. The pharmacological trigger had been removed. The next question was whether the injury would reverse. The impasse. Over the 14 days that followed, the patient was managed first in the medical intensive care unit and then on a step-down cardiology service. He was started on heart failure-directed therapy, including an ACE inhibitor and a beta blocker. His eosinophil count normalized by day 5. His C-reactive protein fell steadily. A repeat echocardiogram at 2 weeks showed an ejection fraction of 55%. His heart had recovered. His psychosis had not. As the clozapine cleared, the voices returned. They returned quickly, and they returned with force. By the end of the second week, he was again refusing meals because he believed the kitchen staff had been instructed to poison him. He could not sustain a conversation for more than 90 seconds. The interval of lucidity he had found on day 15, the interval in which he had asked about returning to university, had closed. This is the impasse that gives cases like this their weight. Clozapine remains the only antipsychotic with demonstrated superiority in treatment-resistant schizophrenia, and the only one with a specific indication for reducing suicidality in this population. For a patient like this one, the alternatives are not alternatives in any meaningful sense. They are the treatments that have already failed. The team convened. Cardiology argued that a Rechallenge carried a non-trivial risk of a second inflammatory event, and that a second event might be fatal rather than reversible. Psychiatry argued that untreated treatment-resistant schizophrenia is not a neutral baseline, that chronic psychosis has its own mortality, its own disability, and its own progressive destruction of a life course. An ethics consultation was requested. The patient's mother, on a video call from 2 states away, asked whether her son would ever finish his degree. The literature on Rechallenge after Clozapine-induced myocarditis is limited and historically cautious. In a 2018 systematic review, Manu and colleagues identified 17 rechallenges after myocarditis, 11 of them successful, but concluded that routine rechallenge could not yet be recommended on the available evidence. More recent reviews suggest a more favorable, though still imperfect, picture. Richardson and colleagues identified 22 successful rechallenges among 34 cases. A 2024 review in CNS spectrums reported sustained success in approximately 69% of 45 cases. These numbers must be interpreted with caution. Case report literature is vulnerable to publication bias, and failed rechallenges are less likely to be written up. Even so, the signal is no longer trivial. Across the published cases, successful rechallenge tends to follow a consistent structure: slower titration than the package insert recommends, intensive serial monitoring of C-reactive protein and troponin during the re-exposure window, close cardiology collaboration, and careful exclusion of patients whose index event involved severe arrhythmia or irreversible hemodynamic changes. This patient's index event had been severe, but it had also been reversible. His ventricular function had recovered fully, and the institution had the infrastructure to monitor him at the level the literature suggested would be necessary. The decision was made to proceed. The aftermath. The rechallenge began 6 weeks later on a medical floor with initial telemetry and with the psychiatry consult service following him daily. The titration was less than half the rate recommended in the package insert. C-reactive protein and troponin were drawn daily for the first 4 weeks, then every other day for the next 4. Cardiology followed him throughout. Repeat echocardiograms were obtained at weeks 2, 4, and 8. He did not develop a second inflammatory event. By the end of the 3rd month, he was stable on 275 milligrams of clozapine nightly. His ejection fraction was 58%. The voices had quieted again, not completely, but enough that he could read without being interrupted by them. He was discharged to a structured outpatient program with close psychiatric and cardiology follow-up. He returned to university the following fall on a reduced course load, with academic accommodations arranged through the Student Disability Office. He did not return to mechanical engineering. He switched to applied mathematics because the coursework required less laboratory time and because he felt he could manage the reading load more reliably. He graduated 2 years later than his original cohort. He does not remember much of the afternoon his heart began to fail. The fever and the psychosis blurred the timeline into something fragmentary. What he remembers, he has said, is the morning the voices went quiet and the feeling for the first time in 3 years that the inside of his own mind was a place he could live in. Closing. Case studies such as this illustrate one of the central tensions in psychopharmacology. The molecules with the greatest therapeutic power are often the same molecules with the greatest potential for harm. Such tension is a structural reality of the clozapine titration. Success is predicated on rigorous surveillance and the ability to distinguish expected titration effects from true toxicity, ensuring the patient survives the initial multisystemic stress to achieve long-term functional recovery when hope for such had been lost. This has been a clinical and molecular analysis of clozapine-induced myocarditis. For Psychopharm Archive, I am a consultation liaison psychiatrist and academic physician. Subscribe for our next investigation into the molecules that shape the modern world.